I think you can start now.
Recording started, sir.
I started. Everything started. You start now.
Good evening, everyone. I welcome you all on behalf of ISA Online PG class. And before we start further, it's our custom to invoke the blessing of Ma Saraswati. And
Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
I'm audible, sir?
Yes, madam, you are audible.
So different positions are given to the anesthesia patient during surgery in order to provide good surgical access. However, each position is accompanied by physiological changes and carries some risk to the patient. We'll be discussing all this issue in the coming this session. So before we proceed further, I request our Honorary Secretary, Dr. Bajwa sir, to please say a few words.
Thank you, Ridhima. Yes, regarding the patient positioning, today we have got a seminar, and the best part is that the teacher is also our own teacher, Dr. Madhuri, with her, and along with her is Dr. Basavaraj Kalapur. He is also excellent teacher, and their student is excellent student who will be smiling now and be presenting the class on patient positioning. Regarding the patient positioning, I will say the positioning in these online classes, I think these classes go for 2 hours, and all the anesthesiologists keep sitting on the 2 hours on the chairs or on stool, something like that. That also has to be modified. In the online classes, keep the video off for some time and just keep on moving so that the patient positioning, the way is a prone position, supine position in the table, or head up, or head tilt, or Trendelenburg, or something like that. Similarly, we are not what anesthesiologists are doing. So we are sitting in the same position for 2 hours. So we have to start changing that position also frequently. So every position, as she rightly said, there's a different anesthesia complications, and many other aspects also have to be looked into. And all these things, they're very, very important, because we have come across many injuries also, many complications also, with the present day medical legal aspects coming into, to the fore. So these are very important for a postgraduate student, as well as the practitioners, as well as the academician, because whenever you are going to face these type of complications later on, people can pull you to the court also, because positioning, when the patient is positioned in a different manner, you may not be able to access the patient. You may not be able to see or whatever to monitor the patient. So all these aspects, they need a good elaboration today. And I think no better than Dr. Madhuri Kurdi, Dr. Baswaraj, and the student, they can express it better. So let's start. Or back to you.
Thank you, sir. Today we have with us my co-coordinator, Dr. Aarti Jadhav. Madam is Assistant Professor, TY Patil Medical College, Kolhapur. I welcome you, ma'am. And
Thank you,
as such, Madhi ma'am needs no introduction, but she's a wonderful, exemplary teacher and a very approachable friend, and always ready to help us. And Professor Sir Dr. Baswaraj also is a well-known name. But still, as a custom, I request Dr. Aarti ma'am to kindly introduce our moderator of the session.
Okay, Ridhima, thank you. So, Dr. Madhuri ma'am is a professor and HOD of Department of Anesthesiology from Karnataka Institute of Medical Sciences, Hubli. She has done, her major achievements are, she's a postgraduate teacher and examiner since last 27 years. She is Associate Editor, Weber, the official e-newsletter of ISA National, Associate Editor, Indian Journal of Anesthesia in 2022-2023. She is Assistant Editor of JOACP, and she has done advanced 1-year course in medical education. Regarding publications, she has authored 100 indexed articles, 1 book, 4 book chapters, and 2 national advisories. She has received awards ISA IJA Best Peer Review Award in 2016-17 and ISA Proficiency Award in 2021. Her areas of interest are medical education, research, and publication. And today it is really a happy moment or a pleasant day for me because Dr. Madhuri ma'am was my examiner in 2014. She has taken my viva and practical exams of my MD anesthesia. So welcome, ma'am. I'm really happy to be with you today.
Thank you. Thank you so much, Aarti. Thank you for that introduction. It's a very proud moment for me also to have my examinee here with me today. Thank you so much.
And our next moderator is Dr. Basavaraj Kalapur. He is a professor in the Department of Anesthesia, Karnataka Institute of Medical Sciences. He had joined the department in 2006 as assistant professor. He has done MBBS from JJM Medical College, Davangere, and MD Anesthesia from Jain Medical College, Belgavi. He has done fellowship in neuroanesthesia from NIMHANS, Bengaluru. His areas of interest are neuroanesthesia and critical care. He has been instructor for emergency care and life support course conducted by Jeevan Raksha and Rajiv Gandhi University of Health Sciences. He is an instructor of American Heart Association recognized advanced cardiac life support course since 2016. He has published several original articles in national journals. He has delivered talks in state conferences and CMEs. His hobbies are endurance training. He has attended triathlon and swimthlon events regularly. Welcome, sir.
Thank you. Thank you for that introduction, Aarti. Thanks.
So before we proceed, a small announcement that mics will be muted during the session. And if you have any queries, you can type in the chat box. All queries will be addressed at the end of the session. So now I request our moderator to kindly introduce the speaker for today. Dr. Janvi.
Yeah, it's an honor for us to be moderating this session, this seminar on patient positioning and associated risks in anesthesia. So it will be presented by our postgraduate student, Dr. Janvi Reddy, and myself and Madam will be moderating this seminar. Over to Dr. Janvi. You can start your presentation now.
Thank you, sir. And good evening, everyone. I welcome you all. I am Dr. Janvi from Karnataka Institute of Medical Sciences, Hubli. And I am going to present about the topic patient positioning and associated risks under the guidance of Dr. Madhuri Kurdi, Head and Professor of the Department, and Dr. Basavaraj Kalapur. Thank you. Now I am going to share my slides to all of you. Patient positioning and associated risks. Today, I am going to discuss about introduction, physiological considerations of positioning, general positioning considerations, specific positioning considerations, including complications, and conclusion. First, the purpose of patient positioning is to facilitate the surgical procedure so they can comfortably do the procedure, and the patient should be also in a comfortable position. So, proper positioning is essential and requires the cooperation of entire surgical team. Positioning of a patient for surgical procedure is a compromise between the what anesthetized patient can tolerate both structurally and physiologically and what surgical team requires to assess the anatomical target. So establishment of intended surgical procedure may be modified to match the patient posture and also further according to the surgeon who is operating on the patient. And significance of various positions in which patient is placed during an operation and their physiological considerations I am going to explain today. And I am also going to explain about the techniques of establishing the positions and potential complications of each position. First, physiological considerations of positioning. There are complex physiological positions are involved in our body to maintain our body hemodynamic status as narrow as possible, and it is maintaining the blood pressure and everything in a narrow range without much fluctuations. These essential mechanisms are maintained to perfuse the vital organs such as brain, heart, kidney, etc. And for example, when a person reclines from upright to supine position, initially venous return to heart increases, and it will increase the preload and stroke volume, and it also increases the cardiac output. Increasing the cardiac output will increase the arterial blood pressure, which in turn activates the baroreceptors, which are present in aorta. In aorta, baroreceptors are activated via vagus nerve, and the baroreceptors present in wall of the carotid sinus are activated through glossopharyngeal nerve. And these two baroreceptors are activated, which in turn activates mechanoreceptors present in atria and ventricular heart, and these will cut the sympathetic outflow to muscles and splanchnic vascular beds. And finally, atrial reflexes are activated, which in turn regulates the renal sympathetic nerve activity and plasma renin and arginine vasopressin activity and atrial natriuretic peptide. By the above all mechanisms, the cardiac output and heart rate will come down, and it will reach to hemostasis in the new position, and hemodynamic stability is maintained. And in general anesthesia, in normal patients, the responses are like normal and they are not blunted. But under anesthesia, these all responses are blunted, and any hemodynamic change, it will be exaggerated and presented as exaggerated. This is specifically important in sitting position, as sympathetic response causes vasoconstriction in order to maintain cardiac and cerebral perfusion, because it is an upright position. And most of the anesthetics nowadays we are using, they will blunt the pathways which are causing the hemodynamic stasis to be stable. And these pathways are blunted because of the anesthetics and also causes vasodilatation. And spinal and epidural anesthesia will cut the sympathetic system completely and reduce the preload and blunts the cardiac response. So we should be more careful in case of spinal and epidural anesthesias. Usually, while patient is awake and not under anesthesia, all the muscles, including diaphragm and all the muscles of respiration are used, and normal breathing pattern is observed. But when chest wall is, when patient is in supine position and under anesthesia, the lung volumes are changed and tidal volume will decrease. Functional residual capacity is also decreased, and closing volumes will increase. Functional residual capacity is the amount of the air present in the lungs after forced expiration. It is there to maintain the alveoli without collapsing. So if that functional residual capacity will reduce in case of anesthetized patients, and the tidal volumes will reduce in case of anesthetized patients. Hence, ventilation perfusion mismatch will come, and it will also cause to bilateral lower lobe lung atelectasis, and it will also lead to reduced minute ventilation. So we should know like what to do and how to manage the patient under anesthesia, and also consider all the aspects of respiratory system and cardiovascular system. So we will use the positive pressure ventilation and muscle relaxants to reduce the ventilation perfusion mismatch, and it also reduces the atelectasis of bilateral lower lobes of the lungs. And it will also ensure the adequate minute ventilation. Minute ventilation is the multiplication of respiratory rate and tidal volume. So in case of normal patients, it is 12 to 18 cycles per minute. So we should maintain the respiratory rate according to that, and we should also maintain the ventilation perfusion, and we should also reduce the atelectasis of the lower lobes of the lung and maintain the adequate minute ventilation. So any movement on the diaphragm, like in supine position, if patient is lying down, the diaphragm is moved caudal, cephalad, it will causes the compression on the lungs, and it will also reduces functional residual capacity. So it will also causes the reduced minute ventilation. So any movement in the patient, we should take care of the respiratory system properly, and according to that, the changes will be made on the ventilator. And if any sudden changes are seen while in an anesthetized patient, it will also increase the intrapulmonary shunt. Intrapulmonary shunt is the blood which is going to the lungs, which is not properly oxygenated. So we should take care that much blood is not going to the lungs without oxygenation. So according to that, we should plan our and general positioning considerations. Usually positioning in anesthesia is a coordination of all the people in the OT, like including surgical team and everybody, to achieve proper position and safe positioning of the patients. So the main principle is maintaining the body as neutral as possible, and so that the alignment of the spine and extremities should be in neutrality as much as possible. And the patient should lie on padded surface, not on hard surfaces. And additional paddeds are added on the bony prominences and other things such as IV lines, monitoring equipments, and the poles. People who are awake, they can feel if the position is uncomfortable, and if they're feeling any pain, they'll immediately change the position. And even if they're having any breathing trouble while lying down, if the patient is awake, they'll change the position as to their comfortable position. But in anesthetized patients, they cannot change the position, and they cannot experience, they can feel the pain, but they cannot tell the pain, and they cannot change the position according to that. So we should make the patient in a comfortable position, and we should anticipate what and all the positions that patient can be comfortable in. Next, we are going to specific positions. Now I'm going to discuss about each position and how the position is kept, and what are the physiological changes, like main physiological changes we will see in that position, and what are the complications we can expect in that position, and what we will do to prevent that complications. First, I'm going to discuss about supine position. Supine position is also called as dorsal decubitus position. It is the most common position which is used in surgical situations nowadays. In this position, head, neck, spine, everything will retain neutrality. So the entire body is at the level, it is very close to the level of the heart, and hemodynamic reserve is very well maintained. This is supine position. So the head, legs, trunk, head and hands all are at heart level, and neutrality is retained by all things. So hemodynamic stability is much better in this position. And the hands should be kept by the side of the body, or like this on the arm board, and padding should be kept on the bony prominences and pressure areas, so that we can prevent the nerve injuries or pressure injuries. It can also kept on side of the body, like complete adduction, and it can also kept as abducted position, but it should be less than 90 degrees. It shouldn't go over 90 degrees because it will cause brachial plexus injury. And elbow should be padded, and if required, other IV lines and monitors also should be padded. All bony prominences such as heel, sacrum also should be padded to prevent soft tissue ischemia from pressure in prolonged surgeries. Arms can be abducted or adducted, or one arm abducted, one arm adducted, and should be placed as neutral as possible and as comfortable as possible without stretch and extension to prevent all kinds of injuries. In adduction, the arms should be placed next to the body. In abduction, it should be less than 90 degrees so that we can prevent the brachial plexus injury. Hands and forearm are kept in supine position. They can be kept as palms facing towards each other, or they can kept as like supination. They can be kept in supination, or they can kept as palms facing towards each other. The palms are like kept to facing towards the body. When palms are kept towards the body, like facing towards each other, it reduces the pressure on spiral groove of humerus, so we can prevent the injury to ulnar nerve. So this position is preferred compared to supination position. This is called as in this, the arms are neutral position, and their face and the palms of the hand are facing towards each other. In this position, the padding should be placed here also, so that we can prevent the ulnar nerve injury. And one more position we can see here is supination of the hand. Two positions can be placed. Arms can be placed in two positions. One is the palms are facing towards each other, and the other one is supination of the arms. Particular attention should be paid to bony prominences like elbows and any protruding objects such as IV lines, monitoring equipments, and poles. Next, various types of supine position are lawn or beach chair position. This is a position which can be considered as a type of supine position, or can be considered a type of sitting position. It is a modification of both supine and sitting position. Supine position, lawn or beach chair position, frog leg position, Trendline position, and reverse Trendline position. First, we are going to discuss about lawn or beach chair position. This is lawn or beach chair position. So lawn or beach chair position is, it is almost as similar as supine position, but the leg end is raised a little bit, like flexion of hips and knees is made to 30 to 45 degrees. That is called as lawn or beach chair position. This position mainly reduces the tension in the back, and it will give support to the back, and it also reduces the back pain. lawn chair position, reduce stress on back, hips, knees by placing the patient hips and knees in mild flexion, that is 30 to 45 degrees, and better tolerated by patients undergoing awake or monitored anesthesia care. As you can see in this picture, the legs are above the heart level, so the venous drainage from the legs is also better in this position, and it also maintains the hemodynamics of the patient well. Abdominal wall tension is also reduced. As you can see here, the legs are slightly flexed. So from xiphoid to pubic rami, the space is reduced. So abdominal tension is also reduced. It is not stretched. Next, we are going to frog leg position. Frog leg position is hips and knees are flexed and hips are externally rotated with soles of the feet facing each other. It is most commonly used to access the areas like perineum, mid-thigh, genitals, and rectum. And this when the patient is placed in the frog-like position, knees are supported so that less stress and pain is felt in the hips after post-operative period. Next, we are going to Trendline position. Trendline position is same as supine position, only we make a head tilt down or up. It is considered as Trendline position, reverse Trendline position. In Trendline position, we'll make the patient head down tilt, head up tilt. Tilting the supine patient head down is called as Trendline position. It is linked to a name of the 19th century German surgeon, Frederick Trendline. He used it for abdominal surgery so he can assess the abdomen better. And during World War I, Walter Cannon popularized the Trendline position to improve the hemodynamics in the patients in shock. This is Trendline and reverse Trendline positions. Applications of Trendline position. It is most commonly used for abdominal laparoscopic surgeries, and it is also used for central visualization of central vein while placing the central venous catheter, and is also used for distension of the central vein. If the head end is down, so the venous return also increases, so it will also helps in improving the hypotension temporarily. It is temporary because by 10 minutes, the cardiac output will come to baseline after placing the patient in Trendline position. And steep 30 to 45 degree Trendline position is also used for robotic prostate and gynecological surgeries. Effect on CVS. As I told earlier, in Trendline position, cardiac output will increase by 9% in less than 1 minute, but approximately within 10 minutes, the cardiac output will return to baseline. And this position is considered essential still, even though the cardiac output will come down by 10 minutes. This position is considered essential part in initial resuscitation efforts to treat hypotension and acute hypovolemia. Next, effects on respiratory system in Trendline position. Functional residual capacity is decreased. It is because when the patient is placed in Trendline position, the diaphragm is pulled up and it will cause pressure on lungs, and it will also lead to reducing of functional residual capacity, which in turn increases the pulmonary compliance, which decreases the functional residual capacity further, and it will cause the patient to ventilation perfusion mismatch will happen in this. So we should take care when the patient is in Trendline position. And it also affects when the patient is positioned in Trendline position. We'll make the patient not to slip from the table, and we'll put the patient in patient positioning straps around the chest. So it will also lead to reducing the pulmonary functional residual capacity and increase in the pulmonary compliance. In spontaneous breathing patients, the work of breathing is increased when placed in Trendline position, but in anesthetized patients, they can't. Ventilator will be delivering the breaths, so airway pressure will increase. And changes in the mechanical ventilator settings can compensate to some respiratory changes, but we can't compensate the whole thing. However, with the patient body habitus and variations in the position, the higher airway pressures, the minute ventilation will change to the we can't maintain the minute ventilation throughout the surgery. So when placed in Trendline position, we should also assess the duration of the surgery and the airway pressures and change in the airway pressures. And testing of the position for better tolerance after giving anesthesia and before starting the surgery is very vital. So we can assess the airway pressure differences, and we can tell if we can continue in the same position for longer period or not. Effects on CNS. Trendline position has an effect on CNS by increasing the intracranial and intraocular pressures. So it is mostly contraindicated in the patients with increased intracranial pressures. For some patients with severe intracranial hypertension, even supine position is not tolerated. So we should carefully assess the patient and we should work up the patient properly before putting in the Trendline position. Intraoperative positioning may have consequences on site selection for central line placement also. For example, if the patient is having increased cerebral venous pressure, we can't put him in the Trendline position, and it is difficult to access for the central line because the distension of the vein and the vein visibility is also reduced. So we should carefully consider for femoral vein selection, for placing the central vein in cases of increased intracranial hypertension, intracranial pressure and intracranial hypertension patients, so that we won't exacerbate the pressure more by changing the position in such conditions. Other effects, prolonged head-down position can also lead to swelling of the face, conjunctiva, larynx and tongue. It can lead to upper airway obstruction. After post-operatively, it will be very difficult to handle the airway. So most of the times, we should consider the position according to the duration of the surgery. And Trendline position also increases intra-abdominal pressure, displaces the tongue up. It might lead to aspiration. So always consider if patient is placing in the Trendline position, it is better to intubate him to prevent the aspiration. Things to be taken care in Trendline position. Prevent patients in steep head-down position from slipping cephalad. So we have to restrain the patient. Usually the supine position. Usually the patient is in supine position. The base of the table, the whole weight of the patient is on the base of the table, this one. So when the patient is placed in the Trendline position, the weight is shifted, the gravity will change. So we have to make sure that patient is not slipping cephaloid. So we have to put straps or different kinds of things to make the patient not slip. Like we can keep the anti-skid bedding, we can keep the knee flexion, and we can use shoulder braces, bean back cradling, and padded cross torso straps. Shoulder braces are specifically not recommended because they can compress the brachial plexus and they can cause injury to the brachial plexus. So usually we won't recommend shoulder braces. If it is medially placed shoulder braces, it will compress the brachial plexus and it will cause injury to the lower part of the brachial plexus. If it is placed laterally, it can cause the upper and middle part of the brachial plexus and it will lead to brachial plexus injury. Beanbag pads will also become rigid. They make the beanbag pads rigid by doing suctioning so that they can set the beanbags in a specific shape so that patient won't slip from the table. It is also associated with brachial plexus injury as it is very hard. If shoulder braces or beanbag shoulder immobilization to prevent sliding, additional caution is recommended while abducting the arm. Brachial plexus injury on the abducted side of the arm has been reported in conjunction with beanbag immobilization of the shoulder and steep Trendline position. Next, we are going to reverse Trendline position. Reverse Trendline position is head up tilt, often used to facilitate upper abdominal surgeries by shifting the abdominal contents caudal. It is increasing. The popularity of the reverse Trendline position is increasing as there are more number of laparoscopic surgeries performed by surgeons nowadays. This is reverse Trendline position. Caution is advised to prevent patient from slipping from the table. Same as I said earlier, if it is head down or head up, the patient weight will be shifted and the gravity is also shifted. So we have to make sure that patient is not slipping from the table. Any position where the head is above the heart or below the heart, cerebral perfusion pressure should be monitored so that we might prevent the systemic hypotension. Next, coming to complications of the supine position. As I told earlier, the weight of the patient is completely bear down by the base of the table at the center. So that weight is equally distributed when the patient is placed in supine position. Sometimes patient trunk overlays at the end without the base underneath it in order to improve surgical access or to facilitate the use of specific equipment such as CM for the X-ray. So in this slide, I am telling that the base of the table here, the weight bearing is here, but in some cases, when they want to use this CM, they'll insert the emissions here, so they'll put the weight bearing sides here, and without the table base under torso, the patient table can tilt or tip over. Table tilt or tipping risk is higher in obese patients when the table is in Trendline position. Surgical table weight limits are significantly different. So when we are reversing the Trendline position or reverse Trendline position, we should strictly observe the patient positioning and patient movement so that we can prevent the slipping of the patient from the table. Next, we are coming to back. Next, we are continuing with the complications. Back pain is most common in supine position because usually when we are standing or sitting, we have a curvature in the spine that is called as lumbar lordotic curvature, which is lost while lying down. And in general anesthesia with muscle relaxation and everything, the risk of the back pain further increases as the muscles in the back loses their tone. Mostly paraspinous muscles will lose the tone, so it will lead to much back pain in postoperative period. And patients with extensive kyphosis scoliosis may also require extra padding of the spine or slight flexion of the hip and the knee. Ulnar neuropathy has been the most common complication, although brachial plexus injuries have overtaken the ulnar neuropathies in more recent studies when the patient is under general anesthesia. Regardless of the position, the upper extremities maintaining the head in a relatively midline position helps minimize the risk of stretch injury to the brachial plexus. So the arms should be placed either close to the body or less than 90 degrees abduction, so that brachial plexus injury is less, and head also should be placed in the middle. So stretching of the head from the shoulder is not there, so that we can prevent the brachial plexus injury also. And there is no direct evidence suggests that positioning padding alone can prevent the perioperative ulnar neuropathies. Next, we are going to lithotomy position. Lithotomy position is frequently used for gynecological, rectal, and urological surgeries. The patient hips are flexed 80 to 100 degrees from the trunk and legs are abducted 30 to 45 degrees and placed. The knees are flexed until the lower legs are parallel to the trunk and legs are placed in supports or stirrups. The foot section of the surgical table is lowered or sometimes removed from the end of the table. This is called lithotomy position. Here they have removed the lower. Here they have lowered the lower end of the table and they have flexed the hip and the knees, and they have placed the legs in the support. And in this image, you can see the legs are placed in the stirrups. This image, you can see the legs are placed in the supports with support, and this you can see they are placed in the stirrups. In both positions, the arms are kept as abducted less than 90 degrees and padding is placed under the bony prominences so that we can prevent the peripheral nerve injuries, and the hips and knees are flexed. The hips are flexed 80 to 100 degrees and they are like parallel to the lower body, and pressure near the fibular end is present. So we have to prevent the peroneal nerve injury. So we have to make sure that knees are supported properly. Knees can be supported to these supports or these stirrups. This is also called as candy cane variety of lithotomy position. Legs should be raised simultaneously together and knees and hips are flexed. This prevents torsion and injury to lumbar spine. Padding of the lower extremities is critical, particularly over the bony prominences, to prevent the compromise of leg support, compression of the leg supports. The peroneal nerve is the most common injury because it is present between the fibular end and what support we are giving to the knees. So we should take care here. Because of this, it is more prone to common peroneal injury. So we have to take care that knees are properly supported. If the arms are tucked or placed alongside the patient, then the patient hands and fingers are at risk if they lie near the open edge of lower section of the table. When the foot of the table is raised at the end of the procedure, the fingers near the open edge can get crushed. Strict attention must be paid to the position of the hands to avoid a potential disastrous crush injury of the fingers. This one, in this image, we have placed the hands in the abduction less than 90 degrees. Sometimes the hands can be placed by the body, so the hands will come here. And when the patient, after the procedure, when the patient hands are still by the side of the body, this lower end of the table can get up and it might lead to crush injury of the hands here. So it is preferred to place the arms away from the table in the abduction less than 90 degrees so that we can prevent the crush injury. Arms should be on the armrest far away from the table. If arms must be tucked at the patient side, the hands need to be visualized and confirmed to be in safe position whenever the leg section of the surgical table is manipulated. Effects of lithotomy position on CNS CVS. When the legs are elevated, venous return is increased, causing transient increase in cardiac output, and cerebral venous and intracranial pressures are also increased in healthy patients up to some extent. Effects on RS. Increase in the intra-abdominal pressure and abdominal pressure displaces the diaphragm, cephalad, reduction in lung compliance, and results in decrease in tidal volume and decrease in functional residual capacity, and it will lead to lung compromise. In obese patient, or when the patient is having large abdominal mass, that abdominal pressure might increase more, and it will also cause venous obstruction, and it will lead to decrease in venous return to the heart. As with the supine position, the curvature of the lumbar spine is lost in lithotomy position, so it might also cause back pain to the patient post-operatively. So adequate padding should be kept so that back pain is minimized after post-operative period. Next, lower extremity compartment syndrome in lithotomy position. It is a very rare complication, but it is a deadly complication. It is caused by increased tissue pressure with fascia compartment due to tissue ischemia, edema, and rhabdomyolysis. Inadequate arterial inflow and decreased venous outflow will cause this condition. And it is also due to the direct compression and excessive hip flexion from lower extremity elevation. These all things will cause compartment syndrome in the lower extremities in lithotomy position. Risk factors of compartment syndrome in lithotomy position. If the procedure is long time, then it might lead to decreased arterial inflow and decreased venous outflow and decreased arterial inflow. It might lead to tissue ischemia and edema and rhabdomyolysis, which finally leads to compartment syndrome in the lower extremities. If surgical time is extending beyond 2 to 3 years, then we have to lower the legs gradually. Compromising tissue oxygenation due to blood loss, peripheral vascular diseases, hypotension, and reduced cardiac output are also risk factors which can lead to compartment syndrome in the lower extremities. And higher body mass index will also cause compression over the legs, and it will cause the rhabdomyolysis, tissue ischemia, and it will finally lead to compartment syndrome in lower extremities. Next, we are coming to lateral decubitus position. Lateral decubitus position is most commonly used in thorax and retroperitoneal structure operations, and it is also used in hip arthroplasty, etc. Non-operative side is dependent, and dependent legs are flexed to minimize the stretch of lower extremity nerves. This is lateral decubitus position. In this, patient is turned to one side. This is left lateral decubitus position. The dependent arm is supported with padding so that we can prevent the brachial plexus injury and ulnar nerve injury and radial and median nerve injury. And upper non-dependent arm is also kept on support, and it is also adequately padded so we can prevent the nerve injuries. Dependent leg is flexed so that we can prevent the injury in nerve injuries in the dependent leg, and non-dependent leg is also supported with adequate padding so we can prevent the nerve injuries such as lower extremity nerve injuries such as operator and femoral nerve injuries. Padding is placed between knees to minimize excessive pressure on the bony prominences. At the bony prominences, if the pressure is more, it will lead to peroneal nerve injury. So we have to place the adequate pads between the two knees, and we should prevent the common peroneal nerve injury. When kidney rest is used for this purpose, it must properly placed under the dependent iliac crest to prevent inadvertent compression of inferior vena cava. If inferior vena cava compression is seen, it might causes decreased venous return to the heart, which will eventually causes decreased cardiac output, which will lead to hypotension. This is lateral decubitus position, and placement of the arm should be dependent arm should be placed like this, and this support is to prevent the brachial plexus injury, and this support is to prevent the ulnar nerve injury, and IV lines and monitors are also padded properly, and here non-dependent arm is also padded properly, and head is also supported properly so that head can be placed properly, and that non-dependent eye shouldn't be injured. Patient is laterally flexed while in lateral position in order to gain better access to thoracic cavity or retroperitoneum during renal surgeries. The point of flexion in the kidney rest should lie under the iliac crest rather than the flank or rib cage to minimize the compression of dependent lung. Dependent arm should be placed on padded board and perpendicular to the trunk. In this slide, I tried to explain that when the patient is in lateral decubitus position, to assess the renal area, they will flex the patient some more. So the adequate padding is kept here properly so that we can prevent the injuries. And the non-dependent arm needs to be carefully supported. Neither arm should be abducted more than 90 degrees because it will eventually cause brachial plexus injury. And for some high thoracotomies, non-dependent positions may be needed to be elevated above the shoulder plane, and exposure is increased, so care should be taken to prevent the neurovascular compromise. Patient head must be kept in neutral position to prevent excessive lateral rotation of the neck to prevent the stretch injuries to the brachial plexus. Additional head support is also needed, so that additional head support like this one. Additional head support is also needed so that to prevent the movement of the head so much in lateral position. And dependent ear and eye maybe is also risk of injury. So we should check the ear and eye properly on the dependent side whenever possible. This is the dependent eye. This is the dependent eye and ear. And this is the headrest. So we can support the head and to prevent the motion of the head frequently. And this ear and eye, dependent ear and eye should also be taken care. And we should change the position of the head or lift the head for some 10 seconds to prevent the pressure injuries on the dependent ear and the eye. This is axilla roll. So this is placed to prevent injury to the brachial plexus. This should be placed just below the axilla here, and it should not be placed in the axilla. We should take care that the axillary roll is not moved up to axilla and it is placed just below the axilla. If it is placed in the axilla, it can lead to compression of the axillary artery and brachial plexus, which eventually leads to brachial plexus injury. Dependent brachial plexus and axillary vascular structures are at risk of pressure injury in lateral decubitus position. To avoid compression, an axillary roll is placed below the chest wall, just proximal to the dependent axilla. The purpose of the axillary roll is to protect the dependent shoulder and axillary contents from the weight of the thorax. An axillary roll should never be placed in axilla. It should always be placed just below the axilla. Sometimes a bean bag is used for positioning without an axillary roll. In this position, the axilla should be checked so that it is not placed in the axilla, and axilla is always should be free of compression. And the pulse should be monitored on the dependent arm because early detection of compression of axillary neurovascular structures can be detected through pulse. If neurovascular structures are compromised, then we can see the pulse volume is very low. And low pulse oximeter readings can also be an early signs of compromised circulation. Next, we are coming to effects of lateral decubitus position on respiratory system. In a patient who is mechanically ventilated, the lateral weight of the mediastinum and cephalor pressures abdominal contents on the dependent lung, which favors the overventilation of the non-dependent lung. When the patient is placed in lateral decubitus position, this side is dependent lung and this side is non-dependent lung. So dependent lung is underventilated. Just because of the dependent lung is underventilated, to compensate that, the non-dependent lung on this side, it will be overventilated. At the same time, the effect of gravity causes pulmonary blood flow to underventilated and dependent lung to increase. So ventilation perfusion mismatch worsens and potentially affecting the gaseous exchange and ventilation. Lateral decubitus position preferred in pulmonary surgery and one lung ventilation. When non-dependent lung is collapsed, the minute ventilation is assigned to the dependent lung. This combined with decreased compliance in the position will increase the airway pressure required to achieve minute ventilation. The minute ventilation is the multiplication of respiratory rate and tidal volume. It should be adequate according to the weight of the patient. So if we are placing the patient in lateral decubitus position, we should maintain the adequate ventilation and we should adjust the ventilator settings accordingly. And head down tilt in lateral position worsens the pulmonary function, thereby increasing the shunt fraction. As I discussed earlier, the shunt fraction is the blood that is flowing through lungs, which is not properly oxygenated. Next, we are coming to prone position. The prone or ventral decubitus position is used for surgical access to posterior fossa of the skull, the posterior spine surgery, buttocks, perineal area, and posterior lower extremities. When general anesthesia is planned, the airway is secured by endotracheal tube while the patient is still in supine. This is called as prone position. In prone position, all the pressure points, heel, sacrum, and bony prominences, everything is padded accordingly, and the hands are placed in mild flexion, that is 45 degrees, and placed beside the body to prevent all the nerve injuries and the pressure injuries, and adequate padding is kept. And the head is supported with different kinds of things such as headrest, horseshoe headrest, and everything. Now we are seeing the prone position of the patient in Wilson's frame. Here the arms are abducted less than 90 degrees. Although greater abduction can be needed in certain surgeries, and pressure points are padded and the chest and the abdomen are separated away from the bed to minimize the abdominal pressure and to decrease the pulmonary compliance effects. And soft pillow has kept here to prevent the pressure injuries on the eyes and nose. An endotracheal tube should also be placed properly, and it should also be supported properly while placing the support to the face while protecting the eyes and the nose. Special care should be taken while securing the endotracheal tube to prevent dislodgement while patient is in prone or during changes of the position. An anesthesiologist is mainly responsible for coordinating the move while maintaining inline stabilization of cervical spine and monitoring the endotracheal tube. Endotracheal tube should be disconnected from the circuit while placing the patient from supine to prone position in order to prevent dislodgement. And the monitors are also disconnected from the patient while changing the position from supine to prone. But what monitors are disconnected, it is up to the judgment of anesthesiologist and depends on the patient condition. And ventilation and monitoring should be re-established after turning the patient to prone as rapidly as possible. For the patient under sedation, head may be turned towards the one side if neck mobility is adequate. During general anesthesia, the head kept neutral using surgical pillows or horseshoe headrest or head pins. Weight should be on bony facial prominences, and it should not be on the soft tissues because soft tissues are prone for injury if it is under pressure for longer periods. And face is not always visible, hence mirror systems are available to facilitate intermittent visual confirmation. This is a prone position with horseshoe adapter. This horseshoe adapter can be adjusted according to the facial diameter of the patient with screws, and neck should be in neutral position as much as possible to prevent flexion and extension, which will lead to spine injury or spinal cord injury. And this is a mirror system where a mirror is placed here. And in this picture, the eyes are not covered, but usually the eyes are covered and padded properly. And mirror is placed here so that we can assess the airway, endotracheal tube of the patient is in place or not. Any injuries are pertinent to the patient. Any pressure is there on the patient. Bony structures of the head and face are supported. Monitoring of the eyes and airways is facilitated with plastic mirror. Although not illustrated, eyes should be closed. Eyes should be taped closed. This is a prone position with horseshoe adapter. This is a horseshoe, and it can be adjusted to the face of the diameter of the facial diameter of the patient. According to facial diameter of the patient, we can loosen and we can make the horseshoe bigger and we can make the horseshoe smaller. The face seen from the below, the horseshoe adapter permits superior access to airway and visualization of the eyes. The width may be adjusted to ensure proper support by facial bones. Most pillows support the forehead, malar regions, and chin, and with a cutout for eyes, nose, and mouth. Forehead and malar regions are supported by horseshoe headrest and allow for a reasonable access to the airway. So this is superior as we can access the airway easily through this hole, and face is supported properly on the bony prominences, and soft tissues are not on pressure, which leads to ischemia. Pin fixation, which is most commonly used in cranial and cervical surgeries, is advantageous as there is no direct pressure on the face. And patient movement must be prevented when the head is held in pins. Movement in the pins can result in scalp lacerations or cervical spine injury. And articulating supports must be fully locked to prevent the sudden fall of the head, as failure of the articulating supports may lead to complications when the head falls suddenly. And prone positions, legs should be padded and flexed and slightly at the level of knees and hips. The arms may be positioned to the side of the patient, placed outstretched above the head. If arms are at the patient's side, then they should be tucked in neutral position. If the arms are outstretched above the head, they should be placed on armboard with slight flexion, and padding should be placed under the elbows to prevent the stretch and to prevent the injuries on the peripheral nerves. Extra padding under the elbow may be needed to prevent compression of the ulnar nerve. When the patients are in prone position, weight should be distributed to the thoracic cage and body pelvis, and it should not distribute on the abdomen because it might cause increase in the intra-abdominal pressure and intrathoracic pressure, which will lead to the compression of the inferior vena cava and it eventually reduce the venous return, and it will also causes the decrease in cardiac output. This is done with specific types of prone beds and with foam bolsters. The prone beds and bolsters are placed to support on each side of the patient from clavicle to iliac crest. Placement via the iliac crest will cause the compression of the femoral vessels or femoral nerve, which leads to the injury. Some prone beds include Wilson's frame, Jackson's table, Relton frame, Moradians and Simmons modifications of the Relton frame. This is the Wilson's frame. Here the patient is placed in prone position and the abdomen is distanced from the table and weight is carried on the thoracic cage and the pelvic region. Hands are placed by the body in abduction less than 90 degrees and it is supported by paddings. And heel and sacrum, dorsal part of the legs are also supported with padding. And facial pillows are placed in under the face to prevent the ischemic injuries of the face and the nose. Breasts are also placed medial to the supports such as bolsters, and genitalia should be cleared of the compression. Elevated abdominal pressure can transmit elevated venous pressures to abdomen and spine vessels, including epidural veins, which lacks walls. So while placing in the prone position, it is mostly used for spine surgeries. If the abdominal pressure is elevated, it might transmit the pressure to the epidural veins, which causes increased bleeding in the surgical site. This is prone position with Mayfield head pins. While placed in Mayfield head pins, as you can see, these are sharp objects which are tightened to the skull. So if any movement is there, it might lead to laceration of the skull, and it also leads to cervical cord injury. So care should be taken while placing in Mayfield head pins. Rigid fixation is provided for cervical spine and posterior intracranial surgeries. Position may include neck torsion or flexion that affects the depth of the endotracheal tube, and extreme head positions may lead to spinal cord injuries. Effects on CVS. Increased abdominal pressure may impede venous return through compression of inferior vena cava, decreasing the cardiac output. Effects on respiratory system. Pulmonary function is better in prone position than in supine position. Prone position is used to improve the respiratory function in patients with adult respiratory distress syndrome. It is mostly proved in times of COVID that most of the patients with compromised lung function are placed in prone position because it improves the lung function. Under anesthesia, prone position has advantage over the supine position with regard to lung volumes. And oxygenation without adverse effects on lung mechanics, it is also seen in obese and pediatric patients. Complications of prone position are airway edema, eye injury, pressure injuries, and inadvertent loss of airway, monitoring and intravenous lines. So care should be taken while placing the patient in the prone position. An ET tube should be disconnected from the ventilator while turning the patient from supine to prone, and after turning to prone, we should immediately connect the ventilator to the patient. And prone position is also a risk factor for perioperative loss of the vision. If motor evoked potentials are used during spine surgery or in neurosurgery, then position of the tongue and bite block placement should be frequently checked to prevent the injuries, because bite injuries are serious conditions. Vision loss. Vision loss is only observed in prone position because the patient is placed in prone position, as you can see in the image. As you can see in this image, the patient is placed in prone position, so the eyes are under pressure. If eyes are under pressure for longer time and eyes are not taken care of, then it will lead to vision loss. It is observed only in the prone position. Permanent loss of the vision can occur after non-ocular surgical procedures, especially those performed in prone position. The occurrence of this complication is associated with extensive surgical procedures done in prone position, such as reconstructive spine injury, where there is associated blood loss, anemia, and hypotension, because these all conditions will lead to reduced blood supply to the eyes, and also the pressure on the eyes will lead to ischemia, which eventually leads to ischemic optic neuropathy, which finally causes blindness. Etiology of the vision loss in prone position. Acute venous congestion of optic canal is potential etiology of ischemic optic neuropathy. So use of Wilson surgical bed frame, it's elevating curvature resulting in head being lower than the heart level, and obesity with its potential elevation of intra-abdominal pressure in prone position patient, and long anesthetic durations. Increased estimated blood loss, male gender, and decreased percent of colloid administration are independently associated with development of ischemic optic neuropathy after spinal fusion surgery. So these things all should be taken care of. And if there is increased abdominal pressure, it might lead to increase in the pressure of the epidural vessels, which can lead to increased bleeding in the surgical site. Preventive measures to prevent the blindness in prone position. Limit the duration of the surgery and considering the position of the surgery and checking frequent checking of the eyes under pressure or not while during the surgery. Sufficient infusion of intraoperative colloids and crystalloids so that sufficient blood flow is there for the eyes, and continuous monitoring of the position of the patient. Next, we are going to sitting position. Sitting position offers excellent surgical exposure to upper part of the cervical spine and posterior fossa. Gravitational venous drainage of the blood decreases in operative field, thus reduces the surgical blood. It will also reduce the bleeding in the surgical site, so it is easy to operate for the surgeon. This is called a sitting position. Sitting position is adopted for shoulder surgery. It is also called as lawn or beach chair position. Lawn or beach chair position is a modification of either supine position or sitting position. This is a modification of sitting position. It is also called as lawn or beach chair position. The arms must be supported to prevent stretching of brachial plexus without pressure on the ulnar area of the elbow. Here. And as with all head positions, blood pressure should be regulated with the height of the brain in mind. For the surgeon, its advantage than lateral liquidus position as it provides superior access to the shoulder both from anterior and posterior aspects and potential for great mobility of the arm at the shoulder. Access to the airway is excellent in sitting position while compared to other positions such as lateral liquidus position, supine position and prone position, and facial swelling is also minimized and pulmonary mechanisms are also well preserved. Lawn or beach chair position, it is a variant of sitting position commonly used for shoulder surgeries. It is really a semi-sitting position with head of the patient is more reclined than in traditional sitting position. Head of the patient is more reclined. This is traditional sitting position and the head of this patient is somewhat reclined compared to the traditional sitting position. It is called as lawn or beach chair position. And this is a sitting position with Mayfield head pins. The patient is typically semi-recumbent rather than sitting. The legs are kept higher level so that venous return will increase. Arms must be supported to prevent shoulder traction, stretching of the brachial plexus to prevent the injury of the brachial plexus. And it is commonly used, and arms are placed on the abdomen and supported in some surgeries. And head support is preferably attached to the back section of the table to allow the back of the back to be adjusted or lowered emergently without first detaching the head shoulder. Complications in sitting position. Hypotension. Hypotension is the most common problem in sitting position. As the patient is sitting, the pooling of the blood is seen in the lower limbs and venous return is also decreased, which leads to reduced cardiac output, which eventually leads to hypotension. It is a very common problem in sitting position, occurs due to pooling of blood in lower body. Mean arterial pressure, systemic blood pressure, and cardiac index are all reduced. Placement of the patient in sitting position should be done in incremental order so that the patient can adjust to the hemodynamic changes according to the position. And intravenous fluids and vasopressors should be ready. Next complication is venous air embolism. A constant concern in sitting position is venous air embolism. In this position, the surgical field above the level of the heart and the dural venous sinuses are tented open. So it might lead to venous air embolism and constant vigilance is required. It also causes, the venous air embolism will cause arrhythmias, oxygen desaturation, acute pulmonary hypertension, circulatory compromise, and even cardiac arrest. If the patient is having patent foramen ovale, then the patient is at risk for paradoxical arterial embolism, causing stroke or myocardial infarction. If the embolism is in heart, it might we can detect it by Mill-Wheels murmur, which is a splashing murmur, which is seen when the clot is when the air is present in the heart, and that splashing sound is because of air and fluid levels. A preoperative contrast echocardiography is recommended to evaluate for the PFO. The presence of PFO has been considered a contraindication to the sitting position as it might lead to paradoxical arterial embolism and it will lead to stroke or myocardial infarction. How to detect venous air embolism? Venous air embolism can be detected through transesophageal echocardiography. Usually 3 to 5 ml per kg of air is required to produce a stroke or myocardial infarction. But transesophageal echocardiography can detect as less as 0.02 ml per kg of air, and transthoracic Doppler is also most sensitive monitor with detection of 0.05 ml per kg, and transcranial Doppler is also as sensitive as transesophageal echocardiography. Pulmonary artery catheters, esophageal stethoscopes, and end-tidal carbon dioxide monitors are also less sensitive monitors which are present nowadays. ECG changes and pulse oximeter changes are seen very late. So by the time we detect the venous arterial embolism through ECG and pulse oximeter, it is too late. So we should take the intervention before through these methods. And in ETCO2 monitor, the waveforms will be short rectangle shaped. Treatment for venous air embolism. The first step is we should stop the further air entrainment. So the surgical site, so we should ask the surgeon to stop the operating, and we should flood the surgical site with normal saline, and we can also apply the bony wax to the surgical site. And inspired oxygen should be kept at 100% so that we can cause denitrogenation, which can lead to which can displaces the other gases and which will lead to increased oxygenation, as it is a treatment in hypoxemia and hypotension. And hemodynamic compromise is treated with intravenous fluids and vasoactive agents. Patient can be placed in left side down and Trendline position in order to move an airlock in the ventricular outflow tract. Aspirate, we can put central venous catheter prior to the surgery so that we can aspirate the air through a central venous catheter. Pneumocephalus is other complication which is found on postoperative imaging from cervical or posterior cervical or cranial posterior fossa surgeries performed in sitting position. Tension pneumocephalus, which is the accumulation of subdural or ventricular space causing pressure on the intracranial structures, but it is a very rare condition which is reported after neurosurgery in sitting position. Prompt diagnosis and surgical evacuation of the air is the required treatment. And in normal pneumocephalus, the air is entering in and it is also exiting outside. Entering in and it is also exiting outside. But in tension pneumocephalus,
Is there any problem, Janvi?
no, ma'am. I'm sorry.
No problem.
Sorry for the line. Pneumocephalus is a complication which is found on postoperative imaging from the cervical or posterior cranial fossa surgeries, which is performed.
Your slide is showing first slide. Can you just change it and do the screen share?
Yes, ma'am. Can you see the slide now, ma'am?
Yeah, very well. Please go ahead.
Yes, thank you, ma'am. And pneumocephalus is the complication which is found after sitting position. It is most commonly found in postoperative imaging from cervical or posterior cranial fossa surgery performed in sitting position. Tension pneumocephalus is accumulation of air in the subdural or ventricular spaces causing pressure on the intracranial structures, but it is a very rare complication which is reported after neurosurgery in sitting position. Prompt diagnosis and surgical evacuation of the air is the treatment. Prone position causing quadriplegia or spinal cord infection can be caused by impaired arterial perfusion with hyperextension, hyperflexion, or excessive rotation of the neck. Other complications are macroglossia and peripheral nerve injuries. While the patient is placed in sitting position, we will be placing the endotracheal tube to secure the airway, and manipulation of endotracheal tube can cause the compression of the venous drainage, and it will lead to swelling of the tongue, which is seen immediately after extubation. And after extubation, the tongue is so large, it is enlarged within seconds. We can't intubate the patient again. So tracheostomy is the only option left. So we should take care that macroglossia should not occur and manipulation of the ET tube should be less. Other complications are peripheral nerve injuries. Mostly sciatic nerve injury and common peroneal nerve injuries are observed in sitting position. In sciatic nerve injury, pain is the most common complaint, while in common peroneal nerve injury, we can see the foot drop. Things to be taken care while giving sitting position. The trunk should be, there should be flexion at the trunk. Hip flexion should be less than 90 degrees in order to minimize stretch on lower extremity nerves and to prevent the peripheral nerve injuries. Arms are supported so that shoulders are in slight flexion elevated in order to ensure avoidance of traction of the shoulder muscles and potential stretching of upper extremity neurovascular structures. Knees are also usually slightly flexed for balance and reduce stretching of sciatic nerve, and the feet should be supported and padded. In case of sciatic nerve injuries, the patient feel extreme pain, numbness, tingling sensation, which is radiating from the buttocks to the lower extremities. The patient head must be fixed in sitting position with either rigid pins or taped into special headrest to prevent the movement of the head, hyperextension, hyperflexion, and to prevent the cervical cord injuries. Exact mechanism of cervical spine cord injury is not known, but it is noted in some cases where cervical hyperextension, cervical hyperflexion, or excessive cervical rotation has been implicated as risk factors. Extreme neck positions can impede both arterial and venous blood flow, causing hypoperfusion or venous congestion of the brain. The patient's cervical range of motion should be examined in preoperative assessment, and adequate distance should be maintained between mandible and sternum when the cervical spine is flexed in to provide for the adequate arterial and venous blood flow. Here we can see that the patient is already in sitting position, so the venous flow to the brain is already compromised, and if it is further compromised, it might lead to hypoxia and hyperperfusion of the brain, which will lead to brain injury. Cerebral oxygen saturation monitoring may be helpful, but no gold standard limits exist, and the values can change with alteration of patient position and carbon dioxide concentration. So in laparoscopic surgical setups, the carbon dioxide concentration will be automatically high because of insufficiency of carbon dioxide. So cerebral oxygen saturation monitoring doesn't apply to that conditions. It only applies to the conditions where patient position is almost stable and the patient is continuously ventilated and carbon dioxide levels are very low. Reasonable recommendation for patients undergoing surgery in sitting position are to monitor blood pressure carefully in reference to level of the brain to avoid and rapidly treat any hypotension or bradycardia, and the position of the patient carefully to avoid extreme power so that may compromise cerebral vessels. Robotic surgery and positioning concerns. Urological surgeries and gynecological surgeries are most commonly performed under robotic surgeries, and the general position of the patient is performed under steep Trendline position, that is 30 to 45 degrees, and lithotomy position with arms stuck at neutral position on the sides. Once robot is docked, the direct access to the patient is limited. This is the image of doing surgeons performing robotic surgery. These are the robotic hands placed by the patient, and these are the docks. After locking the docks, the access to the patient is very minimal. So before docking, we should take care of the airway and we should patient positioning so that patient is not slipped from the table and the airway is patent. Here you can see that the patient has given reverse Trendline position, a head steep position of 30 to 45 degrees, and carbon dioxide is insufflated into the abdomen. So it is very challenging to maintain the hemodynamics of the patient throughout the surgery. Physiological changes during robotic surgery are due to laparoscopic insufflation as well as positioning, but hemodynamic changes are largely due to the laparoscopic insufflation, whereas changes in respiratory mechanisms are also affected by position. In this image, you can see the patient is already in the head low position, so the diaphragm is already pulled up and the pulmonary functions are already compromised, and along with the carbon dioxide insufflation, the abdomen is distended, which will push the diaphragm still more further cephalad, and it will lead to further compromise of the lung functions. Effects on respiratory system. Functional residual capacity is decreased in both with both laparoscopy and further decreased with additional adding of steep Trendline position. This is due to combination of pressure of abdominal content from laparoscopy and Trendline position pushing the diaphragm, and can also be worsened by chest fixation that is applied to prevent the patient from slipping off the table. Here the three conditions which is compromising the respiratory system is, one is the patient position. He is positioned in the Trendline position, and the other one is carbon dioxide insufflation, which will cause distension of the abdomen, which will push the diaphragm up. And one more thing is the patient is positioned in the head low position. So he might slip off from the table. So we should take care the patient is not slipping. So we should place the shoulder braces, which will compress the chest and will also cause further compromise on the lung functions. Peak and plateau air pressures have been shown to rise up as much as 50% between changes in pulmonary compliance, decreased functional residual capacity, and need for increase in minute ventilation with carbon dioxide insufficient. Intraoperative mechanical ventilation can be quite challenging during these days. According to the studies, the robotic surgeries are very comfortable for the surgeons, and after docking, they are like a line of curve of learning is also reduced. But for anesthesiologists, it is a very challenging thing. So we have to handle everything. Like we have to handle the airway, and we have to handle all the physiological conditions as stable as possible. The patient must be well secured in order to prevent the slipping in steep Trendline position. So we have to use non-slip mattresses, chest straps. Shoulder braces may be useful, but shoulder braces are also reported to cause brachial plexus injuries due to stretch between shoulder and the neck. If shoulder braces are employed, monitoring for excessive stretch at the patient's neck is essential. The ET tube should be well secured to prevent the migration. Often a tray or table is placed above the patient's face in order to provide protection from laparoscopic equipment. As you can see here, the docking of the robotic docks are seen. So while moving the docks, it might injure the patient's face. So the patient's face is covered appropriately to prevent any injuries to the patient's face. And it may be prudent to trial the steep Trendline by docking the robot to ensure the patient is properly positioned, does not slip, and can tolerate steep Trendline position from a physiological standpoint. So before performing the surgery in steep Trendline in laparoscopic surgeries, because once the robots are docked, we can't undo the docking. So we have to perform the position before docking after giving anesthesia to make sure that the patient can tolerate the position, and we have to ensure that airway pressures are not increased as much, and we have to maintain the stability of the patient, hemodynamic stability of the patient. Next, we are coming to complications of robotic surgery positioning. Eye injury, peripheral nerve injuries, rhabdomyolysis, compartment syndrome were the most frequent positioning complications found in robotic surgeries, which are associated with radical prostatectomies. Airway and facial edema as well as brachial plexus injuries are the most common recalled complications after the surgery. Next, we are coming to peripheral nerve injuries. Peripheral nerve injury is a serious perioperative complication. Most injuries are sensory or combined sensory and motor, and only 14% are pure motor injuries. Usually, peripheral nerve injuries are multifactorial, as sensation is blocked by unconsciousness and regulated anesthesia. Early warning symptoms of pain after returning to normal spontaneous repositioning is absent. For example, if patient is given spinal or epidural anesthesia and patient lower limb peripheral nerves are injured, the patient cannot experience the symptoms of nerve injury immediately, as the spinal action will stay for 4 to 6 hours. So we can't assess the symptoms of the nerve injury early. So we should be very careful. The patient comorbidities such as hypertension, diabetes, peripheral vascular diseases, old age, and heavy alcohol and tobacco use, extremities of weight, both low body mass index and obesity are the risk factors for causing peripheral nerve injuries. General anesthesia and epidural anesthesia will also cause peripheral nerve injuries, and prolonged surgical time because of the pressure on the nerves will also cause peripheral nerve injuries, as I explained earlier. Presence of preoperative neuropathies and paresthesias is important, as injured nerves are more susceptible to injury in a phenomenon described as double crush syndrome. So we have to assess the neuropathies of the patient. If patient is having any neuropathies, we have to elicit all neuropathies, range of motion of the extremities, or the range of motion in neuropathic area, so that we can assess the neuropathy after post-operatively, like if any injury is there or not. We have to assess the degree of neuropathy after the surgery. So we have to know the amount of neuropathy present before the OT. And a condition called double crush syndrome is seen. It is two separate subclinical nerve insults can act synergistically to produce a clinically significant neuropathy. That is, the already injured nerves are more prone for injury, more prone for still more injury. So the already injured nerves are more susceptible. And it is if subclinical nerve injury is present preoperatively, because of the injury in perioperative period, it might lead to significant neuropathy postoperatively. So we should take care of the neuropathies, and we should assess the neuropathies preoperatively, perioperatively, and postoperatively properly. Positions that permit stretching of the nerves and pressure to anatomic locations known to carry nerves prone to injury must be avoided, such as ulnar nerve tunnel and peroneal nerve coursing over the fibular head. Padding and support should distribute overweight. No padding material has been shown to be superior. Whenever possible, the patient position should appear normal, natural. The most common nerve injuries happening due to positioning are ulnar nerve injuries, brachial plexus, radial nerve injuries, femoral nerves, sciatic nerve, common peroneal nerve, and obturator nerve. In ulnar nerve, it is most commonly seen in males as the fat pad is less in males, and sensory deficit is seen along the course of the ulnar nerve. And in brachial plexus injury, the most commonly observed thing is wrist drop, and the sensory deficit over the course of the ulnar nerve, and motor deficit over the course of radial and medial nerve. So brachial plexus injury is a mixed motor and sensory deficit injury. In radial nerve, we can observe wrist drop. In femoral nerve, we can observe foot drop. Common peroneal nerve, we can observe foot drop, and also sensory deficit over the superior part of the thigh and anterior and medial part of the leg. In obturator nerve injuries are seen while doing the forceps delivery forcefully. That time they can injure the obturator nerve, and it will lead to the peripheral nerve injuries. And sciatic nerve most commonly will present with pain, numbness, and tingling sensation, which is radiating from the buttocks to the legs. Evaluation and treatment of perioperative neuropathies. When a nerve injury becomes apparent post-operatively, it is essential to perform and conduct a directed physical examination to correlate the extent of sensory and motor deficits with the preoperative examination as well as intraoperative events. As I said earlier, if any neuropathies are present preoperatively, due to the stress of the surgery, it might exacerbate the neuropathy post-operatively. So we should assess the preoperative neuropathy properly so that we can know post-operatively any increase in neuropathy is seen or not. And if any neuropathy is observed post-operatively, we should seek neurological consultation, and we should also ask the help for the neurologist so that we can localize the site of the lesion and determine the course of the treatment, and we can guide the prognostication. With proper diagnosis and management, most injuries can be cured within months to years, but it also requires physiotherapy. Conclusion. The positioning of the patients under anesthesia carries major responsibility, requiring great attention to detail and constant monitoring. Positioning for optimal surgical exposure, but for lasting harm to the patient from improper positioning must guide the actions. The final position should appear as natural as possible. That is, the patient should be comfortable, and patient should tolerate when he is awake or unsedated for the required duration of the procedure. These are my references. And these are the previous year question papers. Discuss the anesthetic problems of surgery in prone position, various patient positionings during anesthesia and the complications, various indications and disadvantages of Trendline position during anesthesia and surgery, and how can this be prevented. Diagnosis and management of venous air embolism. Enumerate the causes of air embolism in clinical practice. Discuss the clinical features and its management. Thank you.
Thank you, Dr. Janvi. I must congratulate you. Very well presented, effortless presentation. And definitely the credit goes to our moderators who have shown us a very well insight of the topic. And for the PGs, I think if you just go through this class, you will get full marks. And Janvi has also helped you sharing all the questions. Ma'am has given you and sir has given you a great hint for all the PGs. I think the topic is well described, but as it custom, I'll ask Dr. Aarti ma'am to kindly read any questions. And house is now open. Anyone if want to ask them questions.
Ridhima, let me discuss the topic because it is a seminar. We will first discuss the topic and then we will go on to the questions. And I also saw in the chat box that many of our senior teachers have put very good points in the chat box. Yes, which I think you should read out, and all postgraduates should hear those points. Okay. Definitely. So starting with the discussion. They say that life is full of adjustments, and we anesthesiologists have to really adjust with everybody, and most important with the surgeon. So similarly, when the surgeon gives a particular position to the patient, the particular position is given to the patient for the benefit of the surgeon, right? So that he or she gains good surgical access. But this position may not be favorable to us and to the patient physiology. So the patient also has to adjust to this position. So Janvi has explained in depth about the common surgical positions that are adopted and what are the physiological implications of these positions, how to carefully give these positions, and what are the various complications associated with various surgical positions. Now, if it is an unanesthetized patient, as she said, the unanesthetized patient, he or she is quickly able to adjust to sudden changes in position because all his reflexes will be intact. But so can anybody tell me, or can Janvi tell, what are these compensatory mechanisms for able to adjust to sudden changes in position in an unanesthetized patient?
Yes, ma'am. For example, if the person is reclined from supine to standing to supine position, it will lead to the increased venous return to the heart, ma'am. So it might lead to increased cardiac output also, increased stroke volume and increased cardiac output, and it will lead to increased arterial blood pressure. So the blood pressure should be maintained in narrow range, and we have to get the blood pressure to the normal level. So that baroreceptors present in atria via vagus nerve will be activated, and the baroreceptors also present in walls of the carotid sinus also activated, which will lead to mechanoreceptor activation present in the atria and ventricles. These atria and ventricle mechanoreceptors will reduce the sympathetic outflow to muscles and vascular splanchnic beds.
Okay, and so Janvi, can you tell which are those vagal reflexes which help the patient, which help in the adjustment to the changes in position?
Like for example,
the Herring-Brewer reflex. Have you heard of it? The Herring-Brewer reflex. Then the Bainbridge reflex. The Harrison and Marsh reflex. So yes, can anybody tell what is this Herring-Brewer reflex and Bainbridge reflex and how they help in adjusting to this change in position? Can anybody amongst the attendees tell? I think Dr. Surekha has raised her hand, Ridhima. Let her tell. Dr. Surekha, unmute yourself.
Good evening, ma'am.
Yeah, can you tell what is that Herring-Brewer reflex?
Yes, ma'am. Yes,
yeah, please tell. Please tell.
Ma'am, this Herring-Brewer reflex is there. These are the impulses from the pulmonary baroreceptors, which are carried centrally by the vagus nerve, ma'am. And the stretch receptors are distributed in the smooth muscle of the airways, and they are responsible for the inhibition of respiration when the lungs are inflated to the excessive volumes. And this is called as the Herring-Brewer reflex, ma'am.
Okay. And what about the other reflex I was talking about? The Bainbridge reflex?
Ma'am, this reflex is stretch receptors will be located in the right atrium and cavo-atrial junction, ma'am. When there is a increase in the right atrium pressure or increase in the intravascular volume, this will send the signals to the vascular center by the 10th nerve, ma'am, which is the vagal afferent nerve. And these afferent signals will inhibit the parasympathetic activity, thereby it will increase the heart rate. This is the brain which
yes. So these are the various reflexes which help the patient adjust to the changes. Yes, that's okay. That's okay. Which help them adjust to the changes in the position. So Janvi, can you tell how much is the decrease in vital capacity from standing position to recumbent position in a patient? Janvi?
Yes, ma'am. In standing position.
Yeah.
In standing position to sitting position, the vital capacity will decrease by 20%, ma'am.
Sitting position.
Supine position.
Supine. What yes, about left lateral? 10%. Okay. Yes, Trendelenburg 15%, lithotomy 18%. So they have done studies and found that there are different changes.
Yes, ma'am.
Okay, can you tell what are the cardiocirculatory changes which occur in the Trendelenburg position?
While the patient is placed,
Cardiocirculatory.
yes, ma'am. Yes, ma'am. While the patient is placed in Trendelenburg position, the head is tilted down. So the venous return, the blood pooling in the the blood which is pulled in the lower extremities will be coming as venous return to the heart, which will increase the stroke volume, and the cardiac output is also increased, which will cause the increase in the arterial blood pressure, ma'am.
Okay. So the cardiac rate will be slowed, the cardiac volume will be increased. In fact, they say that it has been found that if you give head down position of 45 degrees, the heart volume and the superior vena cava volume is doubled in volume. It is doubled. Okay. So the stroke volume will be increased, the cardiac output may be unchanged. Then the systolic pressure, diastolic pressure, there can be slight increase. The venous pressure will be increased. The cerebral venous pressure will be increased and the cerebral blood flow will be decreased. So these are various changes which occur in the Trendelenburg position. Ridhima, there is some
Janvi,
kind of disturbance coming from the background. Just check who it is.
I will check. Don't worry. Dr. Janvi, don't worry. These are the DM questions, not MD questions. Okay. The DM questions, so don't worry. Whatever you can answer, it's okay. Otherwise, we are there to answer. Don't worry about anything.
Okay.
These are high profile questions.
So they say that there is an inverse ratio between the vital capacity and the volume of blood in the lungs. Got it? Now, can somebody tell me that if you change the position from supine to upright when the patient gets up, what changes will be there? What changes will be there? Can you tell me?
In cardiovascular system, the venous return will definitely reduce, ma'am, because the patient while lying down, the pooling of the blood is less while compared to upright position. So while in upright position, the venous return will decrease and cardiac output will also decrease, which eventually will reduce the arterial blood pressure.
Okay.
And the cerebral blood flow is also reduced.
Okay.
So some patients might feel dizziness like immediately after coming from supine to upright position.
Okay.
We are talking about under anesthesia or we are talking about the spontaneous?
No. This is after. This is after. And they also say
anesthesia,
that and they also
Janvi, how will patient feel dizzy when the patient is under anesthesia?
No, sir. While awake patients, while suddenly getting up from supine to upright position, they might feel dizzy because venous return will be reduced and cerebral blood flow is also reduced.
That's fine, because make it more simple. When your patient is supine, okay, the level of the heart is at the same level the limbs are when the patient is sitting, and under anesthesia, because the peripheral pump is not functioning, your venous return is going to be hampered. It's okay, na? Make it very simple. Don't worry. These are the classical tricky DM questions. Don't worry.
Okay. So I just wanted to tell you that in the upright position, there is something called as an antidiuretic effect. You know, where the sodium, water, and chloride resorption will be reduced, and there is an antidiuretic effect. Whereas the supine position, and you know, when you rest at night, when you sleep in the supine position, these are known as the diuretic positions, where the resorption of sodium, water, and electrolytes reduces and the urine output increases. Same is the effect of exercise, where you have an antidiuretic effect. Now, Janvi, what is Fowler's position?
Fowler's position is sitting position, ma'am, but head end up is raised to 90 degrees.
Very good. What is semi-Fowler's position?
The lower limb position is also raised and head end position is maintained at 85 degrees, ma'am.
Okay. Have you heard of the jackknife position?
Yes, ma'am. Jackknife position is a modification of prone position. Both the ends of the table will be lowered, ma'am. It is most commonly used for like perineal surgeries or pilonidal surgeries, ma'am.
And have you heard of the kidney position?
Yes, ma'am. It is placing the support over the iliac crest to make the patient as in a position to access the renal area more. It is more commonly used for retroperitoneal surgeries and renal surgeries, ma'am.
Very good. And what happens when you elevate the kidney bridge? Have you heard of the kidney bridge on the OT
Yes,
table?
ma'am.
Yes.
Yes, ma'am.
Yes. So on the left side, there may not be any problem, but if you elevate it on the right side, you have the inferior vena cava there. And you
Inferior
may
vena cava
cause
compression.
IVC compression if it is elevated beyond a certain limit. Okay.
Yes, ma'am.
Then
Yes, ma'am.
have you heard of Simi's position?
Simi's
Simi's
position.
position. It is for surgery on the anus. So there are several positions. Okay. So Janvi, out of
Yes, ma'am.
all these positions, if I ask you to choose a position, which is the position which is best for the patient as an anesthesiologist?
Best for us is head up position, ma'am.
Why?
Because access to the surgeon is also good, and we also can maintain the hemodynamic stability of the patient as close.
So what is the ideal position for perioperative surgical position?
Ideal position is supine, ma'am.
Yes. So the ideal position should provide minimal interference with respiration, minimal
ma'am.
interference with circulation.
Yes,
Then there should be no pressure damage to the nerves and soft tissues, and it should be comfortable for the patient, especially if it is the surgery is being done under regional anesthesia. Okay. Then regarding the air embolism, I think you have already told everything. But what is the name of that position which is given to the patient? You said no, some left lateral position is given to the patient. Right?
Yes,
What is
ma'am.
that? What is the name of that position? You said left side down, Trendline position. What is the name of that position? Durant's position. Durant's. Okay. And one more treatment for your air embolism after you aspirate the air and do resuscitation and all that. You can last ship the patient to ECMO, and hyperbaric oxygen therapy is one more method of treatment. Yes. And what are the contributions of Trendline? What is his first name? Trendline? You were talking of Trendline.
Frederick Trendline.
What are his contributions to surgery or medicine and anesthesia also? Any idea? What are his contributions? At least you can tell about the Trendline position, no?
Yes, ma'am.
Anything else?
Actually, he's not an anesthesiologist, ma'am. He was a surgeon. While doing the surgery, he has used the Trendline position.
Okay.
And he has the surgical. He has the better surgical access.
Okay.
So he.
Anybody else in the audience can give the answer. What is Trendline contribution to anesthesia also?
प्राइस क्या आंसर करने का?
I will give a prize for the one who gives the answer.
करने का प्राइस बोलो तभी बोलेंगे, ऐसा थोड़ा बोलेंगे बिना.
But if you are giving, I am not giving you. Anybody else? Nobody? Okay, so I will only take the prize and I will give the answer also. That he performed the first endotracheal intubation in the very early 1870s. Okay, so though he was a surgeon.
Who taught him? That's another question now.
Who taught him? I don't know.
That's what I'm saying.
I really don't know. We'll have to contact him. Lekin he was the first person who performed the first human endotracheal intubation. And after that, after 3-4 years, Massevan, he reported the first elective endotracheal intubation. He reported it, Massevan. Okay. And Trendline, his favorite was urology. And he also performed ligation of the great saphenous vein for treatment of varicose veins and blah blah and all those things.
अरे तो MCH का question है यार, MCH का, not even DM. MCH urology का question पूछ रहे हैं.
And what would be the ideal position for induction, Janvi? When you induce GA in a patient, what would be the positions for induction?
Supine, ma'am.
Supine, I agree. We are not going to induce anybody in the prone position. Tell me.
Now,
Nor are
now
you
tell
going to
me,
induce
Janvi, this question, if
Yes,
I
sir.
ask in a different format, say a person is having humpback, or the person has got a fused spine, or even a pediatric patient who is weeping and so much, how can you make that patient supine and induce? Now tell me, this is a gold medal question. You tell me a 6-month-old infant, okay, now you want to induce that patient in a supine position, can you do it? Or which is the best position to induce such a patient? Very simple question to a PG student going for exam. A 6-month-old infant, you want to induce for you want to give a GA to that patient, how you will give?
Head elevation, sir.
Head elevation or something else you will employ for a 6-month-old infant. You can't keep the patient on the table. You know, the patient will keep weeping. The patient will keep moving vigorously. You can't give a jabardast anesthesia just holding it arms and those are, I think, obsolete methods now. So how you will do it? That's an induction I want from your side. I'm your external examiner now. Just think, what is the possible way you can do?
Usually we sedate the patient with sevoflurane, anesthetic gas.
Before doing that, see the patient
Janvi,
is
what do you do usually in the OT? You tell that.
Basavaraj is playing the role of internal examiner, pakka internal examiner.
What you do daily, you do, tell that.
That's what I want to know.
In your room only we'll give the we'll give pre-medication, glycomidal, and it will calm down the patient and we'll shift the patient to OT.
How you shift? How you shift?
Oxygen cylinder should be ready, sir, and we should shift with the monitoring of saturation with pulse
We'll take a cylinder, small cylinder with it, or what? The mask and with the oxygen. That's important question. Now you're shifting the patient from the pre-medication room or the pre-operative room to the room operative room, no? So how is you shifting that? That's a very simple thing. This is where the PG falters.
Saturation probe, monitoring of saturation. Sir.
That means somebody has to carry the monitor also. Somebody has to.
No, sir. Saturation probe.
Okay, simple saturation probe you are putting it.
Yes.
And how you will give the oxygen to this patient while it's shifting?
Simple face mask. If needed,
where will the oxygen will come from? The source. It is a long-standing tubing from the OT. It will come out, or you will take some cylinder along with the MOX assembly attached to it. See, very simple. In a day-to-day life, when you are doing the induction, the question was very good. It depends also upon the age, depends on other factors. In a pediatric patient, how you induce? You induce in a stage-wise manner. You can't induce immediately to the pediatric patient. Yes, because you have to secure IV line also sometimes. Yes, you know, now whether you want to induce first or you want to secure the line first. That is another question.
Secure the line first, sir.
How will you secure without induction? The patient will be moving the hands and everything. The lines are very difficult. Sometimes the chubby patient is there. You will not see the vein.
Yes, sir.
Yahi answer kar do. If you can induce a pediatric patient of 6-month-old infant, you are passed today. The day you do, I think whatever you do every day, you observe around you, that is very important. The positioning of the pediatric patient while from the pre-medication room on the table.
Janvi, what do you do to secure a vein? How will you secure the vein?
Mask, ma'am.
Mask with what? Sevoflurane.
Sevoflurane.
Yes.
Then secure the line.
In the pre-operative room, the baby is in the pre-operative room. There is no IV line. Yes, so you have to secure IV line without making the baby cry. How you will go ahead? Any other route of administering a sedative?
Application.
So,
what application?
Lignocaine, ma'am.
Yeah. Janvi,
local application of local anesthetic application.
Yeah, you can put the cream, eutectic cream also, eutectic mixture of the local anesthetic that can make the pain-free securing of the IV line. But it has to be applied 30 to 45 minutes earlier before you secure the line. Okay, you have to plan for it because the child is chubby. You first have to inspect the child when it comes to your operation theater. Okay, that takes time, and then you can use so many methods. You have to take a baby in the lab. You can't put on the bed and you just see keeping the pre-medication, giving them. You put in the lab. Whether you want to give nasal pre-medication or nasal induction or something like partial induction in the pre-medication room or monitoring the oxygen same time, then giving the oxygen at the same time. So you have to do all these things. before,
Yes.
then you take to the patient in a very fast, swift manner from the pre-medication room to the operation table. On the operation table, CVO is ready. CVO is ready, the mask is ready, the monitor is ready, the lines are ready. Already, if you have secured the IV line, it's okay. If you have not secured, at least be ready with the IV lines there.
Yes, sir.
Be ready with the IV lines there. Then I think it's the best time to induce an infant. And from the lab transition to the table transition, the child will be partly sedated now, or maybe sometime more than that sedated. Then it becomes easy to induce in a supine position now. Okay.
Yes,
Good.
sir.
Okay, that's at least you answered this thing. It's a good. You have done well today. Don't worry.
Now I think I'll hand over. Now I think I'll hand over to Dr. Basavaraj. He has got some important questions to ask. Yeah.
Okay. First of all, congrats, Janvi. You have done a wonderful job.
Thank
Okay.
you, sir.
So to continue the, I think there was one question in the chat box about the how do you position a patient with cardiac disease? For example, patient may be having a MS or AS. What precautions you take to position such
Yes, sir.
patients? See, most of the patients who are physiologically fit, most of the time we don't find these problems of cardiorespiratory problems. But what is important is to position a patient who has got a compromised circulatory system. What precautions you will take?
Yes, sir. Usually in mitral stenosis, the cardiac output is already less, sir.
So how do you
we can't preload the heart also because the pumping activity of the heart is compromised because of mitral stenosis.
So,
Yes.
so you just think like physiological effect, you have to blunt these effects. So
Yes,
how you can blunt them?
Basavaraj, I think we'll clear off all the answers that we are running short of time.
Yeah, first of all, we have to optimize the condition. Okay. Suppose it's a CCF patient or MS, you optimize the patient before taking for surgery, that as we do for all patients.
Yes.
Then the other option, the next precaution that you should take is you should put the patient in the required position gradually, step by step.
Yes, sir.
Don't
Yes,
put
sir.
them suddenly. Okay.
Suddenly. Yes, sir.
Then if there is, when you are putting them in gradually, if there is any compensatory changes, suppose there is a hypotension or anything, so you have to treat that condition as you are putting the patient. Maybe use some IV fluids, bolus of IV fluids, or use a vasopressors. Okay.
Yes,
So
sir.
these are the precautions that you can take to put the patient in required position in
Yes, sir.
patient who has got a cardiovascular problems. So one more question is that in steep tendon position, suppose the surgery has gone for say 3 or 4 hours in steep tendon position, and now you have come to you have reversed the patient, so you have to extubate. What precaution you will take before extubation? Any particular thing you want to look for?
Facial edema, facial puffiness, upper airway obstructions we should observe, sir.
Okay,
If anything is there, post extubation, it will lead to upper airway obstruction, and we can't intubate the patient also because of the edema. So we should take care of it.
How you will take care? How you will ensure that after extubation he will maintain the airway?
Test.
What do you do for a thyroid patient before extubation?
Cuff leak test, sir.
Yeah, correct.
Very good.
So,
Yeah.
So you have to do a cuff leak test.
Yes,
Deflate the cuff, see if there is leak around the tube, then you extubate. Okay.
Yes, sir.
In fact, nowadays, sir, there are some DAS guidelines which say that even you can extubate a bit with the head up position, that would be favorable for the.
Yes, ma'am.
Yeah.
It also prevents
Next question. Basavaraj, next question in the chat box. I think there is one question on robotic surgery. What would be the ventilatory strategies to be adopted for a patient for a surgery being a robotic surgery, gynecopelvic surgeries, right?
Yes.
There is a question. Ridhima, chat box questions.
Yeah.
Yeah, there is a question. So I think I can answer that. There are studies which have compared pressure controlled ventilation with volume controlled ventilation, and it has been found that pressure controlled ventilation is better because the compliance is better, the peak airway pressures are lower, and the CO2 clearance is also higher. and you can give moderate PEEP of around 4 to 8 centimeters of water.
Yeah.
Any
There's
other-
one more question, ma'am. What is the position in pregnancy preferably? Somebody has asked, Yogeshwari.
During laryngeal surgery,
Positioning in
During
pregnancy.
pregnancy, yeah.
Which kind of surgery? Can that person elaborate whether it is for section or for non-obstetric surgery in a pregnant patient? See, position in a pregnant patient, most important, we have to remember the supine hypotension syndrome. So you have to give manual displacement of the uterus. And the physiological changes of pregnancy are there, which we have to keep in mind whenever you're giving any complicated surgical position to the patient.
And one has
Yeah.
asked,
There is
Any
one
other
question.
questions?
Janvi, there's one question. How to treat post-operative visual loss? How to treat or
We can't treat the postoperative visual loss, sir. It is a preventive. We can take preventive measures to prevent the vision loss.
yeah,
But
go ahead.
once
How do you
loss
prevent?
is
How do you prevent?
vision, it can be prevented. First, we should make sure that eyes are not under pressure.
No, I think she has covered all that. Janvi has covered all that. How to give padding and how to prevent the vision
She has
loss.
covered. Yeah,
But
you
still,
can.
so many case reports are there of visual loss
Yes.
after posterior
Continuous
spine
weakness.
fusion surgery. Just 1 minute. Posterior spine fusion surgery or anterior cervical surgery, spine surgery. There are case reports of vision loss. So, suppose you have a patient, Janvi, who
Yes, ma'am.
today she has undergone posterior spinal fusion surgery. And
Yes,
tomorrow morning, the surgeon gives you a call stating that the patient is having loss of vision, maybe unilateral or bilateral. What will be your next strategy?
First, I should assess if it is because of the anesthetic complication or because of
How
any
will you
surgical
assess? How will you assess? It may be due to anything. First, you have to see now what it is.
Yes, ma'am.
Will you not subject the patient to investigations?
Yes, ma'am.
What investigations? Fundoscopy.
Yes, ma'am.
Of course,
Yes,
you
ma'am.
have to do a clinical examination first and then fundoscopy, MRI, all those
Yes, ma'am.
things have to be done. Then you have
Yes,
to find out if intraoperatively there was hypotension.
Yes, ma'am.
And I think in the chat box, there was one question by Surekha Shinde ma'am. Why is it that male gender is more commonly this post-operative loss of vision is there in male gender? See the chat box, Ridhima?
ma'am, I'm looking at that.
Then
One
you
more-
tell her.
I'm just reading it. One
Read
question
out all
is
the
that,
questions.
L. Lord Davis position, Janvi. Lord Davis position and its complication. Lord
Lord Davis.
LLOYG, Lord Davis position
Lord
and its
Davis
complication. Janvi,
Yes, ma'am.
do you know?
I think whose question is this?
It's Muthu Kumar question is this. It's basically, Janvi, derived from the Trendenberg position only, but the legs are abducted to assess the anus. Okay?
Yes, yes, ma'am.
Yeah. There are many such positions. Yeah, go ahead with the more other important questions, Ridhima.
Yeah. Steel anesthesia, somebody has asked.
No, madam,
is
that
that?
is answer for how to induce a child.
Yeah.
Somebody has
That
So
is
I
done.
think
suggestion.
the
That
child
is
is
covered.
sleeping. The child is sleeping. So you induce it while the child is sleeping in mother's lap,
Yes.
usually.
Yeah.
Ridhima,
And
just tell the points which are there in the chat box. Some teachers have put some points, just read it
Yeah.
out for the students.
Dr. Millen has written excellent session, and they have written it's all. Is it right to remove all the monitors while rotating patient from supine and prone and vice versa?
It depends on anesthesiologist, ma'am. We don't have to remove all the monitors. Some monitors will be like we don't have any problem with the monitors while we are shifting from prone to supine, such as ECG leads. We can secure the ECG leads with tight tapes, and we are doing from supine to prone. There is no problem if we don't have to remove the ECG leads also. And IV lines, we can't keep IV lines while turning the patient from supine to prone position. So it depends on anesthesiologist to keep which monitors and not to keep which monitors while turning from supine to prone position.
Okay.
And it also
Okay.
depends on patient factors.
Okay. Ridhima,
Dr.
I think we will.
Raghunandan
Ridhima?
sir has said, ma'am, excellent session presentation, and he has also written that cervical spine surgery position is very important. And he said he saw one case which has come to NH for tracheal injury due to flexometallic endotracheal tube, which was used, got flexed and it might have injured. It's us, I think Shah is sharing his experience. Dr. Raghunandan sir.
Okay, next.
One question from me to Janvi.
Yes, sir.
In prone position, what is
Yes,
your
sir.
preferred position of the head? Either neutral position, or you want to tilt to right or left? And how do you select the patient? In prone position, the position of the head.
Sir, if neck mobility is adequate, we can keep the patient neck in lateral position, sir. But if neck mobility is not adequate, we should put in the neutral position with the support of headrest. The headrest might be a pillow or any horseshoe headrest also. And horseshoe headrest is superior because we can access the airway easily in horseshoe shaped. But on the pillow, we can't access the airway properly. So I prefer horseshoe headrest, sir. And
also patients who have got cerebrovascular disease,
yes,
patients with carotid or vertebral defects
These
of
problems
circulation. So
placed
better
in neutral position.
put them in neutral position. Don't
Neutral
turn them
position.
to right or left.
Neutral position is superior to lateral position.
Lateral position. Okay,
Yes.
good.
What if there is cardiac arrest in the prone position? Basavraj,
Yeah,
I think we can just tell this. Let us tell this answer. I think she's very tired, Janvi.
Okay. So
Because you are the expert, no, in
So
resuscitation.
See if you have time, like if there is the patient is not being tied to the table with all the straps and all, if you can make the patient quickly into supine after cardiac arrest, it's well and good. Otherwise, the American Heart Association recommends that you can perform cardiac chest compressions even with the patient in the prone position with your arms in between the two scapulae, okay, at the level of the C7, at the angle of the scapulae, and the rate and depth are the same. And you can also give shocks with the paddles placed anterior and posterior or side by side also, okay. And what they recommend is you place a soft pillow below the sternum. You just turn the patient and place a soft pillow below the sternum so that there is a firm support for the sternum. And you can perform CPR as you do in any other patient with the rate, depth, everything remaining same. That's the recommendation by American Heart Association.
Dr. Sushma has written excellent presentation, and they've asked, can reverse Trendelenburg causes endobronchial intubation, and how we detect and prevent? Janvi, can reverse Trendelenburg causes endobronchial intubation?
Yes, it can.
Yes, ma'am. Yes, ma'am.
And how you prevent and detect it?
The ETCO2 drop wave changes will be there, ma'am, and saturation drop also we will see, and we have to auscultate immediately bilateral and lower lobes also. We should immediately pull out the tube if any air entry is reduced on either side.
Excellent. Yeah.
So one has asked, what do you mean by recalled complication? I think you mentioned in your one of the slides.
Yes, ma'am. Yes, ma'am.
Please tell.
During anesthesia, the patients we will give the patients midazolam to prevent the recall of the events during the surgery, ma'am. But sometimes some incidents will be recalled. That in some cases it was like recorded that some kind of injuries like peripheral nerve injuries can be recalled after surgery, which was happened during surgery.
Recalled means remembering those problems. Okay.
Yes.
Yeah.
Yes,
Yeah.
yes.
Yeah. Anything else?
Yes, ma'am. Dr. Milan has written excellent session and very nice question. I think there are all praises full of this.
Okay. Any inputs, any important scientific inputs are there? You just tell. No need. No, the appreciation is.
Just Dr. Milan has written, awake renotomy position anesthesia consideration should be taken care. And if there is anything that you can promptly say, Janvi.
I think that answer. No, that answer Basavraj will give. He is expert in awake craniotomy. He will tell you.
Oh, what is the question? What is the question?
Ma'am, sir, awake craniotomy position anesthesia main consideration for positioning.
Nothing particular except that here the patient is awake. So always we can consider his comfort level and alter the position of the, say, for example, the limbs and all as the surgery goes by.
Exactly. I
Yeah.
would like to add here that even when we sleep in the night, our body moves. We keep changing our positions. Whatever position we adopt while sleeping, that position is never there in the morning. So our body keeps on adjusting to those positions. And so even in the anesthetized state or awake state, we as anesthesiologists have to take care of our patient as we would take care of a baby. See that all his physiology is maintained and the pressure points are taken care of and all his vital functions are maintained. So I think, Ridhima, most of the questions have been covered.
Yeah.
And to summarize, I'll summarize the topic that no, somebody has added over here that a Trendelenburg cannula was found by him. Something, no? There's something in the
Yeah,
chat
was
box.
found by him.
What is
which
that?
was
Read it.
used. Trendelenburg cannula 1871, in 1870 probably it is, was found by him, which was used to prevent aspiration of blood during oral surgery. Trendelenburg cone provides
Great.
inhalation anesthetic with chloroform dripped onto a funnel. These are his anesthetic contributions.
Very good, very good, very good. Thank you, sir, for those
Thank you,
inputs.
Muthukumar sir.
Okay, thank you.
And
And
Dr. Suretha has written that proning and deproning should be gradual, avoid collapse, and cared for the genital organs. She has written for the PGs, Dr. Surekha Shavan.
yes. So to summarize, I think I've already summarized that you have to take care of your anesthetized patient. Whatever position has been given to him, you have to take care of him or her like a small baby. Take care of all the physiology. If he cannot maintain the physiology, you have to make modifications in your technique, in your drugs, and see that his all the vital parameters are maintained, and take care of his nerves, all his peripheral nerves, his vision, and the ultimate result has to be a good post-operative outcome and patient safety. So with this, I really I appreciate Janvi for the amount of hard work and effort that she has taken to present this seminar, and she has prepared it in a very short time, and I really appreciate her for that. And I thank my co-chairperson, Dr. Basavaraj, and I thank Bajwa sir for giving an opportunity to us to present this seminar before you today. Thank you very much.
Thank you, ma'am. Thank you, Dr. Madhuri, ma'am, and thank you, Dr. Basavaraj, sir, for this opportunity. Pleasure to present in ISA national platform, ma'am. Thank you, sir. Thank you, ma'am.
Thank you, Madhi ma'am. Thank you, Basavaraj sir. Excellent presentation. I think you really put your heart over there, and all the PGs will be benefited. Now I request Bajwa sir to kindly present certificates for our speaker and moderator.
अरे सर्टिफिकेट ऐसे प्रेजेंट नहीं किए जाते, पहले बोलना तो पड़ता है ना कुछ. अरे you have to tell what she has done today. She is answering the DM question. A strict
I have
examiner.
already told she has done excellent presentation.
Arre, you did
stand in
not take
front
a
of
DM.
Madhuri ma'am.
She answered those things. The DM people used to be answering these questions. You know that. Really, Janvi, you did well. I know it's not a short time. It was the shortest time you prepared. I think I told you on Friday or maybe Saturday. So you did in 2-3 days. You did a well at least prepare. That time should also be told to everyone. And I think you are prepared for almost answering everything. And every answer cannot be, even on this platform, sometimes the questions can be confusing. Sometimes they are asked in a different manner. That's the way the examiner used to ask, to make you confused, to make you a little panic, to make you a little anxious. But I think you kept your calm and you were not making any blunders. That's more important. So anyway, has already been conveyed to me to present the certificates. So at least I will be presenting the certificates. Is it visible, the screen?
Yes, sir, visible.
So first certificate goes to the teacher, Dr. Madhuri Kurdi madam, for her excellent preparation for the student, because she is doing herself also along with that. That's a matter of pride for us. The teacher of our PG Concline classes, she's doing it today.
Thank you, sir. Thank you so much.
that Dr. Basavaraj, he was equally good, and he has to handle all the specialist questions, you know, which he was asking. Craniotomy, he was specialist. Other things also specialist. CPR also specialist. So thank you, Dr. Basavaraj. So
Thank
this
you,
is
sir.
time felicitation
Thank you,
for
sir.
you. Then Janvi, this is your certificate. Okay. So you are getting a national certificate for your national class participation.
Thank you so
And
much.
Dr. Arati Jadhav, you also came today. This is your first appearance on the
Yes.
national platform, and
Yes,
I
sir.
think you will be coming very frequently onto this type of classes.
Yes,
So
sir. Sure, sir. Thank you, sir.
thank you very much for coming and doing the good job here. And Dr. Ridhima, as usual, you were handling the last things very, very, very fast, so to finish the things on time. So I really thankful to you also. So these are the felicitations from IS headquarters. So excellent thing. Now I think the next class I will be telling you in a day or two. The message will keep coming to everyone. If anybody wants to suggest something today, before we just 1 or 2 minutes, at 8:35 we will close. If anybody wants to suggest or give suggestions or the feedback or experience, they can unmute themselves and they can raise their hand and ask. Anybody? Because we have to appreciate our students who are appearing on the national platform. Yes, Dr. Thakur Bhai, please. Unmute yourself first, unmute yourself.
Good evening, sir.
Good evening, good evening.
Sir, I have given in the textbook focus regarding the paradoxical air embolism. Actually, I joined in between. Previous, I haven't heard.
Okay. So you want to start it right from the beginning, or shall we ask Janvi? After certificate also you have to answer. See. See.
No. I think I will answer for Janvi. She is very tired. I am her teacher.
Very generous of you.
Yeah. So paradoxical air embolism, there are high chances. And especially if the patient has got a defect in the heart, especially if there is a right to left shunt, then the air flows from which circulation to which circulation, Janvi? From the venous to the arterial circulation. And when this happens, it becomes a systemic embolism, and the patient is going to get a CVA, a cerebrovascular accident. So it is a well-known complication, paradoxical air embolism. Anything else?
Yes, this happens because in sitting position, the right atrial position is somewhat lower than the left atrium. So, and the cerebral blood, so during this position, there are chances of paradoxical air embolism. Even in the pin probe point defect also, it can happen.
Yes, agree.
Thank you.
Position or slightly even head up position also it can happen, even in the slightly head up also. When I think the level of the heart also rises as compared to the rest of the body. Anybody else want to add?
Sir, one more suggestion is there in the chat box from Surekha ma'am. For medical legal aspects, in view of medical legal aspects, there should be documentation of position that is must in our notes. That point should be
That's
taken
a good
care
point.
of.
Yeah. Madam is right, because yesterday only at Kolhapur in the CME I was telling about this thing. We are coming out with the different consent forms, because every consent which is being taken in institution to institution, they have got a variable type of consents, the explanation to the patient and the relatives. Now there is a need for a uniform consent form with addition of the columns where we can write that this patient is undergoing this surgery, suppose any surgery, neurosurgery or a cardiac surgery, that these are the particular extra points which requires enumeration and explanation to the patient, and consent for those things also. Definitely position is the matter. That's why the class was there today. It's very important. So next time, whenever we are going to take consent, write a line that for this surgery, anesthesia, we will be taking up this position, and for this position, there are the known complications which can happen, but doesn't happen usually, which can happen, but you have to give a consent for that thing. That line has to be added. Definitely medical legal things are coming up in a more refined manner. Attorneys will take you to the court in a different manner, and you will not be able to sustain your answer. Definitely these things have to be taken in a consent form. I think rather than just on the written consent, it's better if you are going to undertake a very complicated surgery, take a video consent also, where you have properly explained to the patient relative or to the patient himself in their own language. That will be very protective for you in the court of law tomorrow these things happen. Anybody else?
Yeah.
I think, sir, all the questions are addressed and with your. So there is no question, I think, no.
I think almost done. Almost done. Dr. Thakurbai wants to ask again.
Yes. This is for the suggestion for the regarding to the students.
Your voice is getting broken.
Somebody is going this
Sir, your voice is breaking.
Hello.
Yeah.
Audible, sir?
It's audible, but getting broken in between.
Am I audible now?
Yeah, better.
Okay, sir. So this is for the students. If somebody goes in shock, instead of going towards the head down position, better to raise their legs.
Yeah.
This is just suggestion.
These are the golden words of our teachers. Whenever they think the spinal is there, I think when you give the spinal, never lower the head, always raise the legs. Always raise the legs, at least for enhanced venous return, because the peripheral pump is almost paralyzed. So it's better to raise the legs. That's a golden point in teaching also during our post-graduation days.
Yeah. I think I just want to add a bit about the beach chair position, which she told about. So the beach chair position nowadays is given for shoulder arthroscopies, and many cases are done with the beach chair position. And the main advantage of the beach chair is that the brachial plexus is under least amount of stress in this position, and you can even convert it to open if needed. So there's a lot of flexibility there, and it is often used for teaching purpose, especially from the surgeon side. And in this particular position, a lot of hemodynamic changes are known to take place, especially bradycardia, hypotension. These episodes of hypotension, bradycardia occur, and they are doing studies on that as to find out what is the cause of these episodes of hypotension and bradycardia. Okay, so that is one thing about the beach chair position.
Definitely. Actually, the reason for holding this class is because these positions, we have to know about each and every individual, about the physiological changes, about the complications going to happen, and all the pathophysiology should be clear enough, because these positions sometimes make the surgical field very comfortable for the surgeon to give the best result, to the optimal results. Otherwise, what happens? You cannot have an ego that I can't do this position. It's not recommended in the book. These things will do. These things will occur. There's blood pressure will fall. Something like that. We have to at least adjust in such a manner in the operation theater where we can do the best for the patient in a most, balanced side from both sides, for the surgeon side, from the anesthesia side, so that we can give the best optimal position to the surgeon, so that they can have a best, comfortable atmosphere to work upon to give the best result. That is the main aim. And our main aim is to enhance the safety of the patient as well as getting the best result. So definitely position has got a major role. I think every day we are doing it with our own hands. I think we are tilting the table sometime because we don't believe the technicians can do it much better way, the way we want. So with the age, whatever, I think we're growing with the age, we also know that we can make the best position of the table where we can adjust the patient physiological parameters in a good range. I think these are the learning curves, and these classes are very important to learn these things. And I think we will go ahead, we will progress with these type of classes in the future also. Today, wonderful. So thank you to the teachers, to the student, Janvi, you did well.
Thank you,
Again, thank you to our academic facilitators, Dr. Ridhima and Dr. Aarti, who came for the first time, and Dr. Archita sitting almost with her throughout the class with her. That's a good thing, because she will be presenting the next class, I think. So that's great. And thank you everyone for being here. And we will be meeting next week, because this week we will not be having any crisp series or clip series this week. So we will be meeting next Monday. So for the PG online class only. Till then, I can say goodbye, good night, and long live ISA.
Long live ISA.
Long live ISA.